Next in this course, we will review the newborn immediate transition into extrauterine life. But first, please read the legal disclaimer. Objectives of this course includes the ability to verbalize the importance of the immediate transition into extrauterine life, the newborn's adaptation to this transition, your role as a midwife when assessing the newborn during this transition, and the guidelines needed for perinatal care. So why is this topic important? As the midwife, it is your duty to ensure that the infant makes the transition smoothly and without compromise. Prior to the medicalization of delivery, the transition had to occur quickly for survival of the newborn. In the event the infant is experiencing a delay in transition due to an underlying disease process, a congenital abnormality, or birth injury, the provider is able to initiate treatment aimed at minimizing the effects of such illnesses. Let's further discuss the physiology of transition. Transition from a fetus to newborn is the most complex physiologic adaptation that occurs in the human experience, occurring in a relatively short period of time. Transition to extrauterine life is characterized by changes in the circulatory pathways, initiation of ventilation and oxygenation via the lungs instead of the placenta, and many changes in metabolism. Successful transition from fetal to neonatal life requires a complex interaction between the following systems: pulmonary and cardiac. The placenta delivers oxygen and nutrients to the fetus and removes accumulated waste via exchange at the uterine implantation site. Oxygenated blood flows to the fetus from the placenta through the umbilical vein. The fetal pulmonary system, though physiologically functions closer to term, is incapable of directly participating in oxygenation before birth. Less than 10% of cardiac output circulates to the fetal lungs in the utero due to pressure and resistance in the fetal pulmonary circuit. Anatomic shunts favors right to left shunting blood and optimizes delivery of oxygen and nutrients to the tissues. Is characterized by the presence of 3 shunts. 1. The ductus venosus. The ductus venosus directs oxygenated blood from the umbilical vein to the infant's inferior vena cava. 2. The ductus arteriosus, which directs blood from the pulmonary artery to the descending aorta. And 3. The foramen oval, which directs intra-arterial blood from right to left in the fetal heart. The responsibility for gas exchange is transferred from the placenta to the newborn's lungs and pulmonary system at birth. Ventilation of the lungs dramatically decreases pulmonary vascular resistance and creates a tenfold increase in pulmonary blood flow. When systemic vascular resistance exceeds that in the pulmonary bed, right to left shunting through ductus arteriosus occurs. Due to a progressive increase in oxygenation, the increase in PO2, and the elimination of prostaglandins as a ductal relaxant by the lungs. Permanent closure and remodeling occurs within weeks after birth. Paralleling the circulatory changes, spontaneous infant ventilation mobilizes lung fluid into the pulmonary lymphatic system and recruits alveoli to generate the functional residual capacity, or FRC. The FRC requires sustained pressure, functionally adequate surfactant to overcome resistant forces, and normal chest wall lung compliance. The initiation and maintenance of respirations are triggered by a drop in ambient temperatures as the newborn enters the extrauterine environment, along with potent chemicals as a result of hypoxia, hypercarbia, and acidosis. There may be mechanical triggers such as vaginal squeezing, infant crying, and sensory triggers. Fetal lung fluid must be cleared from alveoli, and 2/3 of fetal lung fluid is typically cleared during vaginal birth. The clearance of fetal lung fluids is enhanced by passive forces. For example, bulk movement created by vaginal squeezing and evaporation, epithelial reabsorption, and decreased fetal lung fluid secretion due to hormonal influence in late pregnancy and labor. One major cause of complications of the pulmonary transition includes respiratory distress, a common complication seen in the early neonatal period and is the major cause of morbidity and mortality. The cause of newborn distress varies, but the result is impaired oxygenation to vital organs and inadequate ventilation, accompanied by retention of carbon dioxide and the alteration of acid-base status. Respiratory distress can be an isolated condition, or it can be associated with other problems. It may be due to structural or functional abnormality, or is an acquired injury of the pulmonary system. Symptoms of neonatal respiratory distress will include tachypnea, or more than 60 breaths per minute, at more than 60 minutes of life. This is in fact the earliest symptom of respiratory, cardiac, and metabolic conditions. Neonates may also experience grunting, or a forced expiration through partially closed glottis. Grunting increases transpulmonary pressure needed to stabilize the alveoli and increase gas exchange by delaying expiration. You may observe retractions. This is an inward pull of the pliable chest wall of a newborn on inspiration. Retractions are observed and reported in relation to the sternum and ribs. You may see nasal flaring in the newborn as an attempt to take in more oxygen by increasing the size of the nares and decreasing the resistance of the narrow airways. Hypoxemia or hypoxia may also be seen via a use of a pulse oximetry reading. Additional symptoms of respiratory distress in the newborn may include color changes. Within 10 to 15 minutes of birth, the skin color should be pink. A pale skin color may indicate systemic hypotension. You may observe cyanosis, a blue discoloration of the skin. In acrocyanosis, there is peripheral cyanosis of the hands and feet. This form of discoloration typically occurs in the first 24 hours of life and is considered normal, which may also occur from cold stress. Central cyanosis of the skin, nail beds, mucous membrane, all are more worrisome. Central cyanosis is a late sign and serious one. The fetal hemoglobin levels must be at least 60 to 65% desaturated before cyanosis becomes visible. I want to discuss the importance of thermoregulation and newborn heat loss. Newborns must be supported to maintain their temperature while transitioning from the warm intrauterine environment to the external ambient temperatures. Preterm infants, including late preterm infants, are often deficient in stored fat. They have an immature hypothalamus, which regulates temperature, and may have more heat and energy challenges. Hence, they are at higher risk of heat loss than those of term infants. The four mechanisms of heat transfer affecting the newborn includes conductive heat loss. This refers to the ability to transfer heat to cooler surfaces, such as from the infant's warm body to a cool table or cold blanket. There's conductive heat loss, referring to heat transferred through air currents, such as from an infant warm body when subject to cooler airflow from drafts. Evaporative heat loss occurs with evaporation of moisture, as when a newborn is wet with amniotic fluid, they are subjected to dry and cooler surrounding air. This creates a heat loss. Radiant heat loss occurring from the transfer of heat via thermal waves from the infant's warm body to cooler surrounding objects through the air. Minimizing heat loss and maintaining the newborn in a thermally neutral environment are important in facilitating a normal neonatal transition. Effective strategies will be directed towards limiting any negative consequences of conduction, convection, evaporation, and radiation. One effective strategy is the implementation of skin-to-skin, a highly effective strategy for supporting newborn temperature, also known as kangaroo care, in which infants are unclothed and placed against the bare skin of the mother or caretaker before being covered with the blanket. Skin-to-skin conserves infant heat through tucked positioning and covering, and positively contributes to thermal gain from adult body heat. Skin-to-skin has shown to be more effective for the prevention and treatment of newborn hypothermia than either an incubator or radiant warmer. When heat loss is greater than the infant's ability to conserve and produce heat, the newborn is no longer in thermal neutrality. In such cases, the body temperature drops and the newborn is cold stressed and becomes hypothermic. Hypothermia in a newborn is defined as a body temperature below 36.3 through 36.5 degrees Celsius. This is 97.3 and 97.7 degrees Fahrenheit. And this is measured as an axillary temperature. The consequences of cold stress includes oxygen and glucose consumption, depletion of glycogen, pulmonary vasoconstriction, hypoglycemia, hypoxia, anaerobic metabolism, and metabolic acidosis. Thermal gain can be effectively achieved through heat application, such as an incubator and radiant warmers. Skin-to-skin contact should be universally promoted as an effective and low-cost intervention. And warming options may also include low-tech equipment, such as heating pads, hot water bottles, or temporary chemical warmers, but only if temperatures can be sufficiently controlled to avoid iatrogenic burns. There are some conditions that increase the risk of an abnormal transition. Maternal factors may include chronic hypertension, pregnancy-induced hypertension, diabetes mellitus, renal disease, infection, abuse of tobacco, alcohol, or illicit drugs, collagen vascular diseases, inherited hemoglobin issues, and certain maternal medications. Obstetric factors may include RH or isoimmunization, fetal growth restriction, decreased fetal movements, multiple gestation, oligohydramnios or polyhydramnios, a premature rupture of membranes or PROM, third trimester bleeding, or delivery by cesarean. And lastly, the neonatal factors may include preterm delivery, less than 37 weeks gestation, post-maturity, greater than 42 weeks gestation, SGA, LGA infection, metabolic abnormalities, birth traumas, major malformations, anemia, and an APGAR of 0 to 4 at 1 minute, or the need for resuscitation at delivery. The routine care during this transition may include glucose screening. Blood glucose in the newborn at birth is approximately 70% of the maternal value. Within the first postnatal hour, the newborn's glucose level may drop to as low as 25 milligrams per deciliter. It has been postulated that postnatal decreases in glucose are necessary to appropriately induce physiological processes, such as glucogenesis or oxidative metabolism of fat. These are all necessary for ultimate stabilization of the glucose supply. Blood glucose monitoring is not routine. However, it may be indicated for certain maternal and neonatal conditions. Neonatal conditions that calls for routine glucose monitoring includes prematurity, intrauterine growth restriction, perinatal hypoxia ischemia, sepsis, hypothermia, polycythemia, iatrogenic administration of insulin, congenital cardiac malformations, persistent hyperinsulinemia, endocrine disorders, and inborn errors of metabolism. The maternal conditions in which glucose monitoring is indicated includes the presence of diabetes or abnormal result of glucose tolerance tests, preeclampsia and pregnancy-induced or essential hypertension, previous infant with macrosomia, substance abuse, treatment with a beta agonist or tocolytics, treatment with oral hypoglycemic agents, and late antepartum to intrapartum administration of IV glucose. Some clinical signs of hypoglycemia in the newborn may include hypothermia, again a temperature falling below 36.3 and 36.5 degrees Celsius, mild to moderate changes in the level of consciousness, stupor or lethargy, tremors, irritability, respiratory depression or apnea leading to cyanosis, hypotonia, limpness or inactivity, a high-pitched cry, poor feeding after previously feeding well, hypothermia, and in more severe cases, coma and seizures. Routine medications recommended immediately after birth includes vitamin K and eye prophylaxis. Newborns are at risk for bleeding complications due to their immature hepatic system and their inability to produce several key coagulation factors, which are dependent on vitamin K, hence the need for vitamin K injections. Administration of a single intramuscular dose of vitamin K, which is 1 milligram for infants weighing more than 1.5 kilograms at birth, is recommended within the first postnatal hour. A single application of ointment into the conjunctival sac is recommended within the first postnatal hour to help prevent infection, particularly from blindness caused by sexually transmitted infections. Lastly, let's review the guidelines for perinatal care. During the transitional period, vital signs should be recorded frequently, enough to monitor the infant's condition and provide appropriate care. If the newborn is distressed, vital signs may be required every 10 minutes. If the baby's vitals are normal after birth, Vital signs may be required every 30 to 45 minutes until the infant's condition has remained stable for 2 to 4 hours. Vital signs should be recorded at least once every 8 hours. Measuring the temperature rectally is contraindicated because of the risk of perforation. In conclusion, successful immediate transition to the extrauterine life should be completed within 1 to 3 hours after birth. Although some adaptive processes can fail as late as 24 to 48 hours after birth, less than 10% of cardiac output circulates to the fetal lungs in utero due to the pressure and resistance in the fetal pulmonary circuit. It is critical that neonatal providers, you, the midwives, have a clear understanding of fetal and normal transitional physiology so you can recognize deviations from typical physiology and appropriately manage those scenarios. This transition from intrauterine to extrauterine life requires rapid, complex, and well-orchestrated steps to ensure a neonatal's survival.